Today's session, we're going to talk about futile interventions, what they are, why we should avoid them, and what the problems are when futile interventions are used in the healthcare setting. Again, these are the objectives. Uh, Most of these will apply across continents. Some of what we'll talk about today applies specifically to Australia, but in general, we're talking about things that apply broadly to healthcare practice around the world. Firstly, futility. In ethics, we like to call this the F word. And futility is the setting in which your patient does not have the ability to benefit from something that you might be considering to offer them. And most frequently, we consider this usually a test, a surgery, or a medication. Commonly, though, I think it's more often thought of as a surgery. For example, a cabbage transplant, things like that. But indeed, it could apply to any sort of potential medical intervention. And it's really important to remember, however, that patients themselves are never futile. And so we have to really watch our language when we're talking about this concept of futility, that we're actually not referring to the patient, but we're actually only referring to the intervention and the specific context of that intervention. I think perhaps the most famous case of medical futility is the one that is currently still in process. And if you haven't heard about this case, I think you're probably living under a rock. This is about the young girl who at the time was 13, living in Northern California in 2014, and she went in for what was thought to be a routine tonsillectomy and decompensated and died at the hospital. And sadly, the family to this day refuses to believe that their child is in fact dead. And they want all forms of life support to still be provided, including feeding tubes, etc. And what they've done, because in most places around the world, you can't just keep a dead body hooked up to artificial life support and expect insurance companies or other third-party payers to pay for that. They've actually sent their child to New Jersey for quote-unquote care. And the reason why New Jersey was chosen for this is there's essentially provisions in their legal code which allow people to make religious slash philosophical objections to the declaration of death. And this really came about for the Orthodox Jewish population, but other people who claim to have philosophical or religious differences with declaration of death have sort of latched on to this New Jersey provision and used it to their benefit, I guess you could say. Excuse the pun. But anyway, so this is what's happening. And as far as I know, this case is still percolating along in New Jersey. In terms of Australia, where this podcast is originating from, the Australian Medical Association says in end-of-life care, medically futile treatment can be considered to be treatment that gives no or extremely small chance of meaningful prolongation of survival, and at best can only briefly delay the inevitable death of the patient. And that's from their futility policy. And in terms of nursing in Australia, their code of ethics has also weighed in on this. Basically, what they say is that, yes, indeed, there may be a whole buffet of medical technology that exists, and certainly hundreds, if not thousands, of drugs available. But that doesn't mean you have to give all of that uh, to everybody. Um, so they're very clear to state that here, and I've highlighted that in red text. And as I said earlier, the language is really important. So, for example, I often hear people say, I even read journal articles which use the terminology of futile care. Uh, but in reality, I can't imagine a situation where care would ever be futile. Care would always be something that provides comfort. There would always be a positive note to the provision of care. So I don't believe we should ever use the terminology futile care. Same thing with the phrase futile treatment. I believe that also is inappropriate because that word treatment does have a positive connotation to it. It does imply linguistically that what you're offering is in fact therapeutic. So I also steer clear of that one. Uh, my guidance is that if you're speaking or you're writing a chart note, you should use the phrase futile intervention because intervention is actually a neutral word. So I think that's the much better route to go. So our job as healthcare workers is to sit down and decide two things essentially. Does the intervention proposed have utility, or is this actually a situation of futility? And you can see that these two words are actually very closely linked. They're certainly polar opposites, but very important in terms of this decision making to decide if something should be offered or not offered. So, how are you going to know if an intervention is going to be futile? Certainly, you don't have a crystal ball. Nobody does, but you do have two other things that will be very helpful uh, in your decision making. The first one is your clinical knowledge. So everybody's got some sort of um, clinical skills training, textbooks, and everything else under their belt. So you've got that. And you've also got your experiential knowledge. So, the loads and loads of case history under your belt, the hundreds, if not thousands, of patients that you've worked with that have had similar presentations. You can look back and recall how did these people fare in these certain situations with these typical interventions. That's your experiential history. And certainly you can also turn to the medical literature. There is tons and tons of literature in PubMed, for example, and Google Scholar that you can turn to regarding futility of certain interventions in certain populations. And it also is important to consider that we're not just talking about how an intervention will behave in a patient in terms of the physical, but everything, this whole person care concept. Because, for example, let's just consider transplant for a moment. We know transplantation could clinically benefit somebody, let's say, who's got cirrhosis of the liver. But if they've got psychosocial issues and they're still drinking, that makes liver transplantation futile for them. So you do have to consider the whole person and all their other issues, all the contextual features when you're doing decision making about futility and utility. So these are some examples I like to do in training with people just to get them thinking. Cabbage in a 90-year-old patient with diabetes. So students often say, yes, well, it's because they're 90. Well, it's not necessarily because they're 90 per se, but what is it about a 90-year-old that might not, or might put them in a situation of being not the best candidate for a cabbage? So it's not the number, but biologically, what are most 90-year-olds looking like, presenting like, and then add in the diabetes on top of that. Transplantation in a patient who's septic. We've just talked about liver transplant for somebody who's drinking. There's lots and lots of literature on the issue of artificial feeding in patients with dementia. And then the issue of dialysis, for example, in patients who are chronically non-compliant. Dialysis is something that you've got to do 3 days a week, let's say 6 hours at a time, and you can't present to the kidney team and say, I think I'll just do it 1 day a week. That'll be my schedule. That's not how it works. You sign up for the whole program or you don't get the program. All right? So are healthcare workers obligated to provide futile interventions? And the answer is no. And you can see I've got some red text there in terms of the state of Queensland, Australia. It's a little bit tricky. It's a little bit different and backwards, I hate to say. But in general, there is no ethical or legal obligation. And the question is, are you sure? People get really nervous. I don't know. I think I'm going to have to do this. I could get sued. I don't want to get in any trouble. I better just do it. Well, let's look at what we've got coming here. Medical Board of Australia, for example, the Code of Conduct, Section 312.4. There's an understanding that you do not have a duty to prolong life at all cost. However, you do have a duty to know when not to initiate and when to cease attempts at prolonging life while ensuring that your patients receive appropriate relief from distress. So if the medical board backs you up, I'd say that's pretty darn good. Also from the United States, the American Medical Association. Physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. Patients should not be given treatment simply because they demand them. Denial of treatment should be justified by reliance on openly stated ethical principles and acceptable standards of care. So there you go. Two prominent organizations have written codes of ethics that clearly support not providing futile interventions. And I will say this, you notice in that first line there, they say care rather than intervention. So they probably take another look at that. And also their code is actually called futile care. Now, Queensland, for those of you who live and practice medicine or healthcare in Queensland, it is a bit different. And I've got to say it's out of step, and hopefully someday this will change. But the law will hold the doctor responsible if they make a mistake in their futility assessment. So it's not that, let's say, they had the best intent looking at all the data they had and the decision making that they did. If they made a mistake, they're going to be held liable. So that's not a great thing for doctors in Queensland. Also, in the state of Queensland, if patients lack capacity and a doctor wants to withhold or stop a futile intervention, he must get surrogate consent. So what this is actually saying here, if there are interventions that are in existence and a doctor doesn't want to offer them or tell family about them in a setting of a patient that lacks capacity, he has no choice. He's got to put it on the table. And I think that's really ethically problematic because it's just going to set families up for discomfort, conflict, and stress because there's hundreds of things that are potentially inappropriate, and doctors should not have to discuss them with families and get them riled up about it. Doctors should only be discussing things that patients have the capacity to benefit from. That's what should be put on the table. But right now in Queensland, this is what we got. Pretty sad. So, is it right to question doctors? Doctors, are they making the right decisions? And I think sure it is. And if you're nice about it, I think in collegial, doctors won't mind if you approach them and say, I wonder if this is the right thing to do. I noticed that this patient has still got a feeding tube, or why are we thinking about re-intubating this patient, or whatever it might be. You just have to use the right approach. So why are futile interventions unethical? There's lots of reasons why. One of the big reasons why, if we're trying to do our families a favor, it's not a good thing to give them false hope. So it's just, we shouldn't be going there. futile interventions are also very wasteful. Um, there's many things in medicine that are limited, and other patients who can actually benefit from them need to have access from them. And this includes even things like bed spaces. So if somebody needs to be discharged, we need to get them discharged because there's somebody else who actually needs that bed space. Also, when folks get into the idea that practicing futile interventions is okay, that can easily create a pattern of doing that over and over. It just becomes simple and easy to do, but that doesn't mean it's the right thing to do. And then lastly, and really important, I think, is that a lot of these interventions that are futile can actually be harmful. Um, and Oftentimes, families never consider that part. They've never thought about that. The part that they're thinking about is my family member needs this, and why aren't they getting it? They could be helped if they were getting this. They're not thinking about, well, if you try this, it could be harmful. If you implement this, it's actually not the right thing. That's your job as a healthcare worker, is to educate them about the harms of implementing things that are actually inappropriate. And as an example, got a commentary there about um, a case that I was informed about where uh, an elderly gentleman was who was not a candidate for cabbage, was not a candidate for transplantation, and was taken for an angiogram. And certainly, you have to wonder why this was all happening, because in creating or collecting all this data from the angiogram, what were they going to do with it? Were they going to stent triple vessel disease in the ostium and everywhere else? What was the point? And what sort of information did they give this patient during the consent process? What was he thinking that was going to happen from an angiogram? Anyway, he ended up dying on the operating table due to a stroke. So I think we need to think real hard before we implement some of our interventions. And why are families requesting or demanding fetal information or interventions? I think a lot of times it's because they're in denial. They just can't believe what's happening to their loved one. They can't believe that the status or prognosis is as bad as it is. And teams, if they're not doing everything, if they're not implementing everything, if every machine isn't turned on, if every drug isn't being given at full dose, well, then you're not trying, and you're giving up. Other times too, there's things like, families look around the ward and they see that patients in adjacent rooms are getting these sorts of interventions. They're on dialysis, they're on ventilators, they've got all sorts of pumps, they may have just received a transplant, whatever it is. So they say, well, if they're getting it, why isn't my relative getting it? And sometimes there's a bit of entitlement going on. And certainly there can be the issue of a fear of dying and not being ready to die. And those need to be addressed through the help of social workers and psychologists. We don't want to ignore that, but we don't want to, medicate that, so to speak, by giving futile interventions. Another issue for families, and sometimes even people who work in healthcare, they think that if you stop a futile intervention, you're in fact killing the patient. Well, we know that from an ethics perspective, that's not true. That's not true at all. When you stop a futile intervention, what kills the patient is whatever underlying condition they already have. That underlying condition just proceeds on uninterrupted, and that's what causes the death of the patient, not stopping the intervention. So that's really important in terms of being able to educate families about that in an empathetic way. But also, healthcare workers need to embrace that same philosophy. Now, sometimes you need to stop interventions that at one time were working well, they were providing benefit, but then become futile. And that is, in fact, the right thing to do. And there's many situations in which that can happen, including artificial ventilation, dialysis, feeding tubes, certain medications, and even implanted devices that need to be turned off. So it's not just about not starting something, but it's also sometimes about stopping something that's already been working and doing fine and just becomes inappropriate because of the overall situation of the patient changes. So we've talked a bit about why do families demand or ask for futile interventions. The flip side of that is why are teams giving it? Why are they providing futile interventions? If we know it's wrong, and we know that you don't have to do it, why are we doing it? Well, firstly, it's easy to be passive. It's just simply easy to say okay and not fight it and to cave in. Also, some healthcare workers are fearful of being sued. The problem with that argument is you could be sued for anything. You could be sued for giving great medical care, great medical treatment, perfect medical treatment, but yet there's a bad outcome for some reason, or there is a failure of a medical device due to a mechanical problem, let's say. You could be involved in a lawsuit because of that. So you could be sued for so many reasons. So I don't think that's the thing to fly here in terms of agreeing to give futile interventions. Also, some people mistakenly believe that they've got to provide it, or they philosophically believe that they've got to provide it. And we've talked about those two things already. And for some people, they're already in that pattern now of providing futile interventions. They've always done it, so why change? It's work to change. It's frustrating to change, so they don't see the need to. Another issue is that some people don't want to take the time to make those utility analyses. Yeah, they can be time consuming, and yes, you may have to go to the literature. Yes, you may have to consult with some colleagues or the nursing staff to get the big picture about a patient. Medicine sometimes takes time, so if you're going to do it right, you're going to have to put the time into it. And there's another issue too that I think that's really important is that some healthcare workers feel like people at their hospital, their department chairs, or their chiefs, or their administrative upper ups won't support them if they try to uphold the concept of not providing futile interventions. So that's a big issue that needs to be dealt with from the top down. Hospitals need to have all their ducks in a row. We'll talk a little bit more about that in a moment. So what do you do if you've been approached and asked to provide futile interventions? First thing you need to do is educate those patients or family members that the intervention lacks benefit, it lacks utility. The second thing is include a discussion about how the intervention could actually be potentially harmful. And lastly, remind people that lots of insurance providers, the various third-party payers, whether it's public or private healthcare systems, won't pay for futile interventions. So, if you want it, you're going to have to pay for it yourself and find a provider that's going to provide it through self-pay because institutions won't provide it. So I think that's another point. If you're running into some real conflict with families, sometimes it has to come down to the checkbook for them to back off. So if you've done all this and you're still at a crossroads, this is a perfect time to call a clinical ethics consultation. And there should be a professional ethicist at your hospital, and just give them a page, have them come to the bedside, and 9 times out of 10, they'll be able to get resolution for you. It is very, very, very rare when these futility cases actually end up in the court system. So I wouldn't be too concerned about that. And at all times, be sure that your documentation in the chart is very robust. And if you've got medical literature to back yourself up, be sure you're also including that in your chart note. So this brings us to the point of your own hospital where you're working. Hopefully your hospital has a futility policy. If you don't have one, you absolutely need one. Um, and if you're not sure how to write one, my colleague there has got a website and he's got lots of policies posted, so you could take a look at those and potentially do some benchmarking, find one that you like or a few that you like, and learn from those to create your own policy. But definitely, hospitals should have a futility policy. This is so you can back up your team when you run into these complex situations. Got a list of resources for you here. Again, there's many, many more if you do a PubMed search, but these will get you on your way. Thanks a lot.